This month is Cesarean Awareness Month, and I definitely feel like this is a great topic to end it off with. So here we go. So what is a VBAC and why is it important? A VBAC is a vaginal birth after cesarean. So that means you give birth vaginally after having a C-section. This could be after your first pregnancy was a C-section, or this could fall in between multiple pregnancies. You just ended up with a C-section and then you want to try vaginally again because you already had a vaginal birth before that C-section. When you have a vaginal birth after cesarean, you will go through what's called a TOLAC. So that's a trial of labor after cesarean. And I know these are terms that some people are kind of not pleased with, but for this purpose of this video, I'm just going to use them so that it's easy to understand, okay? So in order to have a vaginal birth after a cesarean, you go through a trial. So you are trialing labor to see if vaginal birth will be successful or not, okay? So that's what those two terms mean. Why are VBACs not that common, or why do they still get pushbacks? It was always set in stone back in the day that if you had a C-section, you'll always be a C-section. And surprisingly enough, this is still a thought process for some people. You can go ask somebody, probably even your mom or a family member, and ask them, you know, if they had a C-section, how was the next birth? It was probably a C-section. And if you talk to some people don't even know that you can have a vaginal birth after a C-section. And this has been a societal thing that has gone into practice, and now it's ingrained in some people that if you've had a C-section, you're always going to have a C-section. That is not true. ACOG, which is the governing body of obstetrics and gynecology, has set different guidelines throughout the years, and the criteria for VBACs have changed over and over throughout the years, and with the help of evidence and with the help of pushback from certain practices, they were able to dive deeper and really be more realistic about the situation. So at first it was once a C-section, always a C-section. Then it went to, if you are to have a VBAC, immediate anesthesia and emergency services have to be available. So that means 24 hours, no matter what time, emergency operations like the OR and anesthesia has to be available. Then it went from that to anybody who is a candidate for VBACs should be granted the opportunity to VBAC. And then it went from that to those who desire home birth are not candidates for VBACs. And then it went to back to everyone should be offered the opportunity, but still use the VBAC calculator and also have emergency operations available if necessary, and that patients should be aware of the hospital policies with that. Because of these guidelines, there was a lot of fear that was implemented into society. Insurance premiums started increasing, lawsuits started happening more often, and practices started getting a little more fearful and just wanted to kind of just take away any issues or possibilities of issues with VBACs. Therefore, a lot of practices stopped doing VBACs. They stopped offering it. And even if the hospital had no official ban on VBACs, you'll still encounter physicians who are just like, no. And unfortunately, this is unfortunate because a lot of people are candidates for VBACs. While having a repeat C-section is more safe than VBACing as far as uterine rupture rates, having a repeat C-section is still not necessarily safe, right? So everyone should be granted the opportunity to have a vaginal delivery after a C-section. There are protective factors that actually help you with having a successful VBAC, and these include having deliveries that are more than 24 or more months apart. So some practices will have guidelines that says that they do offer VBAC, but you just can't have closely spaced pregnancies. If you've had a vaginal delivery before a C-section ever throughout your life, or if you had a vaginal delivery after a C-section, then that gives you a protective factor. So if you've had a vaginal delivery at all during your journey, your pregnancy journeys, then that gives you a protective factor. And then also going into labor on your own gives you a protective factor. And then not using any induction medications. So what do I mean when I say protective factors? The biggest fear that all providers have when it comes to VBACs is uterine rupture. So uterine rupture is when the uterus opens back up, and typically this is seen if you've had a prior surgery, hence a C-section. Now it is rare, but it depends on a lot of factors, which is why it's hard to get studies on this, because you have to have a high amount of people in your study in order to get a good enough information to present this evidence to people. But you don't want a uterine rupture. That could put mom's life at risk as well as baby's life at risk. So makes anybody fearful who is supposed to be taking care of you. So in order to prevent these fearful things from happening, they look at these protective factors to see if you're a good candidate. So if you go to a practice that does allow VBAC, they will have some rules and regulations, meaning no close pregnancies. You cannot be induced for your pregnancy. Like, you have to go into labor on your own. And we won't use any medication typically if you are having a vaginal birth after C-section. So these are some of the protective factors that we have. Now, when you go into the hospital, here are some things that you might see. So when you go into the hospital to deliver and you're a TOLAC candidate, there are certain things that they will do to kind of make sure that they are monitoring you properly. It's hard to determine if you're having a uterine rupture. So a lot of times you may see them monitoring your pain level, which could be off though because you're in labor. A lot of times though, if you're having a uterine rupture, you'll have a pain on one side that doesn't go away. One of the best ways to determine if you're having a uterine rupture is your fetal heart tones, which means you will be monitored continuously. There's not enough evidence or consistent evidence to back this up, but for precautionary ways and to prevent lawsuits, hospitals have implemented continuous monitoring. If you notice a heart tone start to go down, that could be a sign. Another sign is loss of fetal station. So when they do a cervical exam and they felt the baby's head before, and then they're checking and they don't feel the baby's head anymore, the head just kind of disappeared. Obviously it's there, but it's not able to be felt anymore. Then that is also a possible sign of uterine rupture. And then mom's vital signs, and if mom has blood in her catheter, things like that could be signs of uterine rupture. As far as the statement of VBACs should not be done as home births, I will just give you the evidence. I'm not going to give you my opinions on anything, but the guidelines and evidence just show that there should just be a good amount of monitoring on mom as well as access to immediate services. In the event of a uterine rupture, you don't have much time to get to the OR. So that's probably why they did put that statement in there. Once again, I'm not giving you my opinion. I'm just giving you the evidence and the facts so that you can make your own decisions for things. But I know this is a hot topic, and it could go on and on and on. But that's the short version of it. I may do a part 2. I don't know. Anyway, check out my book below. Bye.